Yep, you're live. Hi, everyone. I am so excited for everyone to join us. I am on the road in the Northwest. If you joined us on Saturday for our weekly The Heart of Innovation live radio broadcast, you would have known that my dad and I are on the road up the Northwest coast of America. And it's a little bit in celebration of World Oceans Day, World Ocean Week, and, just celebrating our oceans, getting a little fresh air, feeling the but we are joined today for this edition of What's Up, Doc by Dr. Jonathan Bonilla, and he is in central part of America. We are going to Texas, so I'm on the, in Washington, and he's all the way over there in Texas. Dr. Jonathan Bonilla, straight from the cath lab. Thank you so much for joining us today in between your cases.
Oh, it's my pleasure. Thank you for having me. So I literally just kind of got out of the case right now, so I'm glad I was able to make it.
So I'm hoping it was a success. You want to tell us a little bit about the case and what you were just up to?
Yeah, absolutely. So I had a patient come in. So she's what we call a bad vasculopath, bad peripheral arterial disease, circulation problem in the arteries in her legs. She came to us last year, and the typical what we call risk factors. When I was in New Orleans, we used to call it the New Orleans bundle: diabetic, high blood pressure, high cholesterol, overweight. The perfect storm, basically. And so years and years, you throw in some years of cigarette use in there. Arteries become hardened, narrowed, blocked, and she's got to the point where she had severe walking pain and even rest pain. And rest pain's a pretty ominous sign. And so we were able to bring her back, and she had some work done on her right leg before, and I suspect she probably wasn't taking some of her medicines. But we did have her in the PVD rehab, and she did very well. So when I took a look, it was very challenging in the case itself, but kind of from the waist all the way down to below her knee was almost completely occluded. So it was a good thing we got there when we did. I had to pull some fancy maneuvers, but I was able to open the arteries all the way up down to the foot, and she's in recovery, doing very well right now. But yeah, typical patient we have here: walking pain that leads to almost rest pain, severe blockages because she has no good flow into there. So we're able to help her out.
So we had that question that came in earlier today from actually anonymous, who was wondering, why is it that so many patients end up being asymptomatic until they get a wound that won't heal, and why doctors don't test for it and potentially treat it until you get textbook leg cramps?
Yeah, it's a very good question. The reason is when it comes to leg pains, there's so many different causes. It's a process that doesn't take days to weeks or even months or years. It's a process that takes decades worth of damage to the legs. So how that plays into the legs themselves is that the body's an amazing thing. So rather than immediately just lose blood flow to the leg, this process, which takes almost years to decades, the body develops these little natural reroutes or bypasses. We call these collaterals. So it goes around these areas that the blood flow can't go through. And so for a while, you're able to get good blood flow down to the foot, but it's never as good as your original blood flow, the direct blood flow. So that's when the walking pains start. And walking pains can be mistaken for lower back pain, neuropathy, or nerve pain. It's all kind of the symptoms overlap a lot, especially in the early stages of PAD. And so by the time these patients are diagnosed, they're already pretty advanced. I think one of the issues is awareness. Definitely, we in medical school we are taught about this, but we don't kind of apply it to practice a lot unless you're in that field. And so I think a lot of these patients just kind of slip through the cracks. And so by the time they get over to us, they're already pretty well advanced. The whole process of getting to that point is just years and years of more damage with all these other risk factors: high sugars, high cholesterol, high blood pressure, a lack of exercise or walking. So that combination kind of makes things worse. And so then on top of that, you throw into the patients just don't like going to see the doctor until something's really bad. So I think all those things play a role in there.
I'd like to open it up to Julie. Julie, go ahead and unmute and ask Dr. Bonilla your question.
Hi, doctor.
Hey,
thank you. So I have a question. I had an abdominal aorta ultrasound done where they found a lot of I can't say it, but atherosclerosis in
Yeah,
the aorta.
sure.
But I also have I have leg pain. However, it doesn't hurt when I walk. My legs don't swell. I can pretty much walk, as far as I want. But when I lay down at night to go to sleep, or if I'm in a sitting position driving, it feels like someone is stabbing me literally all over my legs. It hurts terribly. And it happens, I'll lay in bed, I'll be in bed for like an hour, and it just constant stabbing, shooting pains all over my legs. And then when I stand up to go get Tylenol or whatever, the pain does go away. So it seems like it happens when I'm laying down or when I'm sitting. And I'm kind of worried about that. Plus, I'm worried about the fact that I did have the arterial Doppler ultrasound recently done on my legs, but I don't know how to read the report. So I do know it says there was no occlusion. So apparently that means no blockages, but then they have all the numbers, and I don't understand what that means. Yeah, the velocities, and I don't know how high, low they're supposed to be. So
yeah, and that's okay. That's for us to kind of figure out and take into the clinical picture. Yeah, just because so atherosclerosis is basically just hardening of the arteries. That's what that means. So the fact that the abdominal aortogram that they did, or the ultrasound, showed that you had atherosclerosis means that there's early processes beginning there of circulation issues. Not to say that you're going to develop those in the future, but the arteries become hardened. Arteries are very elastic. They have to be to accommodate all the blood pressure that the body's circulating through. With all those risk factors I had mentioned before, those arteries become hardened. When they become hardened, that's when the problems start. Because we're trying to get all this blood flow through a very rigid structure at that point. Doesn't necessarily mean you have blockages. Now, this is a perfect example of kind of what I was alluding to before, why it's very, in some cases, it's the diagnosis of PAD, especially in the lower extremities, is delayed. And it's because there's other things that can imitate or mask leg pain that's related to circulation. What you're describing is more of what we call, well, let's just take a step back. Claudication is walking pain, and that's the typical pain associated with PAD in the lower extremities, and it's in the muscles usually. And so there's different types of claudication. In this case, when we talk about circulation claudication, we call that vascular claudication or vascular walking pain. But also there are other components or other reasons that neurogenic claudication, in other words, nerve pain when you walk, is very it can overshadow or confuse a picture of PAD. And what you're describing, just the typical teaching when it comes to nerve pain, it's a positional pain. The nerves that come from the brain, they run through the spinal cord, especially in the lower back. They're over the years with motor vehicle accidents, repetitive injuries, those nerves become inflamed. The spinal column becomes inflamed and it pinches those nerves, and that can cause pain in the legs. That's usually a positional pain. You're laying down for a good amount of time. You're sitting down in one position for a good amount of time, or you're standing for a good amount of time and you get pain that kind of runs from the course of the back all the way down the legs. That's more consistent with nerve pain. The typical traditional pain associated with circulation is a walking pain. However, in the setting of having hardened arteries and atherosclerosis, a very simple test to get that you can ask your doctor, your specialist, whoever treats you for this, or you're comfortable with, is what's called an ankle brachial index, ABI for short. What that does, you check the blood pressures on the arms, you check the blood pressures by the ankles. That difference there gives us a specific number, and that tells us if you have any degree of peripheral arterial disease or circulation problems. It sounds to me like this is more of a neurogenic, classically neurogenic sort of thing. And again, I'm not giving you any medical advice here over the line, but from what the story is, it sounds like it's more a neurogenic type of pain. But given the risk factors of atherosclerosis, in this case, what I would do as a provider, theoretically or hypothetically, would be to order this ABI test. It's a very simple test. It's cheap, it's quick, and it gives us a lot of information if it's related to the legs. But it just sounds like that's more of a nerve type of issue. If I were to kind of, again, hypothetically say that's probably what I would be thinking.
Okay, doctor. Now I know they said it was severe
Mm-hmm.
atherosclerosis of the aorta. And
Yeah.
and I don't know why, because I've never smoked. I'm not overweight. I I try to watch what I eat and things like that. So I don't know why that, really happened.
Yeah.
So, seeing
So,
as they said severe, that kind of scared me. And the fact that my legs do that at night or when I'm just sitting, it's very, very painful. But I do know of that test you're talking about. I did read about that, the ABI. Um,
mm-hmm.
um, and I'd like to get one of those done. So I'll have to figure out. I don't have very good luck here with the doctors. I mean, I just feel like they really don't. I mean, you just explained to me more than my doctors have in the past year. I did suffer. I was in a very bad auto accident about 8 years ago, and I did break both of my feet. Both feet were broken. And ever since then, I've felt that problem when I laid down and when I'm sitting. So perhaps it was nerve damage in my back from the accident. I really don't know, but I
Yeah,
appreciate
that's
your,
yeah. I think one of the things, and I'm kind of smiling as you're telling me this because I get this a lot also. And unfortunately, as physicians, we're very guilty about doing this, is we don't take the time to kind of sit down and talk about things the way we're supposed to in detail, and in a way that our patients can understand. We have a tendency to speak doctorese or a tendency not to explain anything at all. One of the things that we run into a lot as physicians is we become so overwhelmed with all the imaging, the tests, the patients, that even things that may be normalish or maybe benign, we don't get back to the patient. A lot of times, no news is good news, but no news is also, it can be alarming news for the patient if they don't know. And so sometimes, then on the other end, sometimes we have to push our providers also to kind of do things, especially in the setting where our patients are feeling bad. And we have an idea what's going on. I think it's never a bad idea to sit down and talk with your doctor about this, whether it be a primary doctor, a vascular specialist, cardiologist. And it's a very simple conversation. Hey, listen, I'm having back pain. Sounds like it's some type of claudication. I have risk factors. What do you think about an ABI? The physician, when you throw it
okay.
out there like that, it's kind of like, oh, well, you know what? ABI might not be a bad idea, rather than saying, hey, listen, I talked to this guy and this, and I did my Google doctor search and I need
Yeah,
an ABI,
right.
right? But it's different. So I think it's totally reasonable to get that done with the physician. Now the atherosclerotic part to this. So whenever it comes to atherosclerosis and hardening of the arteries, and this is circulation in any part of the body. So there's three main areas of circulation. You have the coronary cardiac circulation, the heart. You have the peripheral, which is outside, and usually the aorta all the way down to the toes, and then you have upstairs the neurologic circulation. So strokes up here, heart attacks here, and then leg pains and more acute issues down here. But it's all a continuum of the same process, hardening of the arteries. Now, the risk factors for having hardening of the arteries, there's two main groups that categorize this into. Number one, things you can change or control. Number two, things you can't change or control. You can't change or control genetics, age, gender, or I'm sorry, male or female, whatever you're born with, are born in. Those things you can't change. A female
Right.
over the age of 65 or a male over the age of 55 automatically has an increased risk of having hardening of the arteries and even heart disease and peripheral vascular disease. So you can't change that. And you can't change age. If you have a first degree relative who's had a heart attack, again, male younger than 55 or female younger than 65, or circulatory problems like that in the legs, you're at automatic risk. So these are things you can change. That's one group. Things you can change are what we call the modifiable risk factors, the risk factors we can change. High blood pressure, high cholesterol, sugar diabetes, smoking cessation, unhealthy lifestyle, sedentary lifestyle, and poor diet and obesity. These are all things we can control and change. So in the range of things, and what I just mentioned, you can probably kind of think about what your risk factors are, whether that's things you can change or things you can't change. And if you can change them, those are things you can address that are going to help you out long term to reduce progression of that hardening of the arteries. Again, just because you have hardening of the arteries doesn't necessarily mean you have blockages. This is a good time to kind of sit down with your either your primary doctor or your specialist to go over which risk factors apply to you and how they can help you out with that.
That's
Okay,
fantastic.
that's
And Julie, where are you located? What city, state?
I live in Hampton Township, New Jersey.
Oh, fantastic. You know, we can help you find a doctor that will listen and that will actually get you, take you seriously and get you that ABI test that Dr. Bonilla
That
is
would be
talking about.
great.
So go
They
ahead and
just,
you can get a hold
yeah,
of me
they
through the
did.
group and message me.
Okay. All right. They did give me, due to this issue, even though I don't have high cholesterol, they put me on a
Mm-hmm.
statin and
Mm-hmm.
a baby aspirin due
Okay.
to the atherosclerosis. I'll learn to say that.
Yeah.
So that's good, but at the same time, I'm 58. I'm never had any issues, so I'm just a little worried about it. That's all.
Mm-hmm.
Now it's great that
Yeah.
you're getting us started, right? And you're taking precautions and you're going to get ahead of it. And it is possible to slow progression through those critical lifestyle modifications that Dr. Bonilla was talking about. And we have a question coming in from Mariana, which I think is
Mm-hmm.
related to this, which is interesting.
Okay, thank you.
She says there was a study when 31 healthy adults took 16 grams of collagen daily for 6 months. They reported a significant reduction in measures of artery stiffness by the end of the study. And it's interesting that Mariana brings this up because we had a patient early on that came to us and she was 90 plus years old, still working as an attorney. And she was diagnosed with PAD when she was 50 years old. And her daughter was a functional medicine practitioner who put her on
Mm-hmm.
high doses of collagen. And she never had a procedure, walked every day and took her collagen. And she believes that that's why she never had a procedure. I don't know if that's true. I don't know if there's any way to prove it, but it's
Mm-hmm.
interesting, Dr. Bonilla, that this study came out saying that there was a significant reduction in artery stiffness after a certain amount of time in this study with people taking 16 grams of collagen daily for 16 months or 6 months.
Yes, I'm not
What do
aware of
you
the
think?
study, but what I can only go on is by what our guidelines and our typical practices are here when it comes to vascular issues. So, a few things we have to be very careful with when it comes to studies. Being an interventional cardiologist, being a cardiologist in general, we're probably one of the most scrutinized professions because we have so much robust data. Everything we do is based on extensive research that's been done over several years to decades. And not every profession can boast that. And so that's why we're so highly scrutinized. But that being said, we can only go by the data. And when we go by these research studies, we have to be very careful. The first thing we have to look at is the source of these studies. The second thing we have to look at is the amount of patients that we're studying in these studies. And then the third thing we have to look at is the type of study that was performed. The best studies that take most of the bias out of these studies are what we call double-blinded randomized trials. Is that you bring a group of patients in, you treat them, you don't know who gets a placebo and who gets the medications, and at the end of the study, you unblind and you see who does better. Those are the true studies, and it has to be a big number of patients. So I can't attest to or answer really to the collagen thing, but what I can tell you is that if it's not a big study, it doesn't fall into that category, and I really haven't heard about it. I can't, give advice on that. I'm always weary about newer studies and health supplements and people that boast one way or another without good data. So you have to be very careful. The data as physicians, as an interventional cardiologist, especially in vascular issues, my recommendations are always data driven and data backed. Even though there's expert opinion, the majority and almost all of it is definitely based on research studies. So I can't really give you an answer on that, but just got to be careful with the type of studies.
And what we always suggest at the Global PAD Association is for a
Mm-hmm.
referral to a dietitian. And when I'm looking for a dietitian, I always look for the
Mm-hmm.
few and far between, which are actual PhDs. And so that's definitely someone that you want to try to get an appointment with because they're more likely to, one, be able to order some advanced blood work, and number two, be able to guide you on exactly which supplements are right for you based on that blood work. And so that's the way we practiced when we were able to get my dad on a proper supplementation diet for him. It was very customized, and we were also very careful and learned, what brands were appropriate, because there's not as much regulation in the supplemental market. So definitely try to get a dietitian who's highly experienced in supplementation, and preferably a PhD. We have another question also from Mariana, and I'm not sure, I'd never heard of this, so it's okay if you haven't either. But I guess in Canada and Mexico, they use something called Deflon, DAFLON,
Hmm.
500 milligrams micronized purified flavonoid fraction, composed of 90%, possesses venotonic and forces venous tone by prolonging the activity of parietal. Oh boy, I'm not sure how I'm doing here. I'm not a doctor.
That's okay.
Norepinephrine.
Hmm.
Did I do at
Yeah.
least partially? Okay. It was
Yeah,
enough
we'll
for
stick with
you
the
to be able
Daflon.
to take it and run with it. Okay.
Yeah.
I'll let you take it from here, doctor.
Yeah, Daflon is a medication that is used in other countries. It's not approved here for use in the United States, unfortunately. And I didn't know about this until a few years ago when exactly this. A few of my patients from Central and South America, they came and they were like, "Hey, listen, I used to be on this medication called Daflon. I had never heard about it, but it's definitely not used here in the United States and not approved for use." From what I understand about the medication, it is a medication that promotes circulation around narrowing or blockages in the arteries in the peripheral vasculature. I don't know the exact dose. 500 milligrams does kind of ring a bell. But what that does, it helps with the from what I remember, the tone of the vessels themselves. So basically, when it comes to circulation, yeah, I always compare it to a tree. You have the tree trunk, which are the main arteries or veins, and they branch off into the distal vessels, and it's comparable to the leg circulation. Starts out with the big arteries, and as it goes down to the feet, and the smaller circulation is microscopic. The microscopic circulation is one that's affected first, and so this medication apparently helps out with that as far as the tone, and it kind of protects from what I understand. But aside from that, I can't go any further into that because I just don't know because we don't use it here. It's not approved for use here, but I have run into it a few times, and it is approved in South America, Central and South America, if I'm not mistaken.
Yeah, it would be interesting to find out why it's
Mm-hmm.
not approved here. The FDA does have
Mm-hmm.
more stringent standards, and has the not only safety but also efficacy that they have to make sure that they align with. So there
Mm-hmm.
probably is a pretty good reason why it might be,
Yeah. And I'm pretty
might
sure
not be
it's
approved here.
for yeah, I'm pretty sure it's for veins over arteries. I think it's a vein
Yeah, I think
medication, if
so.
I'm not
Venus.
mistaken. Yeah, and yeah, to your point there, I got to admit, we're probably one of the country in the world with the most stringent um, rules and regulations when it comes to medications, drugs, and even studies. Our cardiology counterparts in Europe, the European Society of Cardiology, a lot of times their guidelines are updated a lot quicker than our guidelines, and so we're usually a couple years behind when it comes to that. Now I know this
Yeah. Do you
medication's
ever
been out
find
for
yourself frustrated? Where do you have
yeah.
do you have a list of wishes for certain things that you wish would be you had your hands on?
Oh yeah, that'd be one of them. But in some cases, because of
Yeah.
the guidelines give us some room to work with things, they tell us that expert opinion is okay also in certain areas. And so a lot of times, our European Society of Cardiology and American College of Cardiology, we join and we go to a lot of different conferences together. And so we
Right.
do a lot of things that are not completely with the guidelines, but that we're in that realm of expert opinion. And we use some of those guidelines here.
And there's another drug that we do have here, though, that is used, that is a vasodilator, which is cilostazol or Pletol. That is something that, a lot of doctors, it's really important for patients, I find, to actually ask their doctors about it, because there still are doctors that are not familiar with it. The only thing with that, I'm curious your thoughts, is that the study that I read, it was effective in 30% of patients. And when it's effective, it's really effective. And when it's not effective, the side effects suck.
Yeah, so cilostazol is from the family medications, the kind of aspirin or Plavix are from. It's an antiplatelet. And what it does is it helps with the inflammation in the arteries. The easiest way, and this is what I tell my patients, it makes the blood is not just liquid. There's a lot of different components. You have red blood cells, you have white blood cells, you have proteins, you have platelets. Platelets are the part of the blood which go to areas which are injured. The clot goes off, and those become abnormal or abnormally used in patients with peripheral arterial disease. So what the cilostazol does, it binds to the red blood cells and makes them less sticky, is the easiest way to kind of say it, so that they can travel around those blockages and travel even through those little natural bypasses that your body develops, the collaterals. And so what it does, in essence, it doesn't fix anything. All it does, it helps you walk further without having as much pain. Is what it does, because it makes those red blood cells less sticky. You're getting more blood flow to the area that you weren't. And just like you said, you hit the nail on the head. When it works great. But when it doesn't work, the side effects can be pretty crummy. And usually it's GI side effects, upset stomach, nausea, just makes you feel bad. But when it works, patients say, hey, listen, I'm able to walk, a few more blocks before I get the pain. It's a temporizing measure, basically, before we do anything more aggressive. But per our guidelines, cilostazol in patients who have PAD and who have claudication, walking pain, that should be started before any intervention is undertaken for the most part. Aspirin, a statin, and cilostazol, a trial of cilostazol. It doesn't specify how long the trial has to be, whether that's a week, a couple of weeks, or a few months, but some trial before we actually pursue a little bit more aggressive or invasive type of treatment.
Have you had any patients that have said that they felt like it was working in their legs, the side effects suck, but they seem to dissipate over time, like the headaches and a little bit of the stomach irritation?
Yeah, we have a lot of those patients. Some of them just kind of power through it because they don't want to have anything more aggressive done. Sometimes to help out along the way, we might give some type of antacid medication. I tell, hey, take it with Tylenol. Tylenol is probably the safest pain medication to take with any of these circulation medications, just because it doesn't thin the blood out anymore. And sometimes they'll be able to kind of tolerate it, eating it with food, obviously. But other times, I just can't take it. So we have to find some kind of other means.
Nancy has a question. Nancy, go ahead and unmute and ask Dr. Jonathan Bonilla your question.
Okay. Hi, doctor.
Hey.
Thank you for being. My part PA, I have peripheral artery disease, coronary artery disease, diabetes, had a heart attack years ago, fighting hard, mostly genetic. But I do take Zetia, and now because I can't seem to get that LDL down lower than 77, no matter what I'm doing. So they put me on a drug called Nexlizet. It's Nexlizet. Do you know anything about that? The hard part I'm having with it now, it is so expensive. It's a combination drug and it's new. And of course, my insurance and Medicare, the copay is over $500. So I'm trying to get financial assistance to get it.
Yeah, so I don't use that medication at all. I'm going to be honest. That medication has Zetia in it, and it has some type of acid. I can't remember off the top of my head, which helps with the HDL. There are other options for patients who are on statins, and we can't get you to that LDL where we want you to get you to the LDL. The best medications on the market right now, and I say that because I've used them ever since they came out, probably a little over 5 to 10, maybe 10 years ago now, are these injectable type of cholesterol medications now. So initially, the class of medications, there's 2 of them. They're called PCSK9 inhibitors. They work differently with statins, but they do work with reducing cholesterol. These have the best reduction in LDL cholesterol that are on the market in the world. It is incredible. I'll have a patient with an LDL of close to 200. I'll put them on these medications for a month, and it'll drop close to 70, below almost to 50, just one month of use. It's a subcutaneous injection, almost like a insulin sort of thing. And the PCSK.
do get one now. I take Repatha.
Yeah, Repatha. Okay.
Okay.
So Repatha, Praluent is another one, and now they have a different one. It's not from that family of medications. It's another injectable. It's called Leqvio, which is twice a year. So these medications in combination with a statin or in place of a statin or in combination with Zetia reduce those cholesterol dramatically. Now,
Can you spell it for me? Look
yeah,
it up.
yeah. Leqvio is Leqvio. That's
Okay.
twice a year injectable. It's different from the PCSK9 inhibitors, which are Repatha or Praluent, which are from the same family of medications. But these are good adjuncts to those medications. Zetia is a good alternative to statin, especially for patients who can't tolerate the statins, the typical myalgias, muscle pains, the joint aches and pains, and nausea. But they aren't as good as the statins. Statins have an anti-inflammatory effect within the arteries also. But in an effort to reduce LDL, because LDL has a lot of data behind it as far as reducing your risk of future disease and death, those are probably the way to go. Now, there's some older cholesterol medications that are kind of last resort for me and other specialists. They're bile acid sequestrants are a group like cholestyramine. And there are I can't remember off the top of my head that they're the type of fibrate medications. These don't work as good, but they do reduce the LDL a little bit. But if we want to get to the newer guidelines, which is less than 55, which is pretty aggressive, I would say probably adding on one of those other injectables, if not switching to a different one to see if that helps out. It sounds like if you're on these medications and you have, it's difficult to get you there. You probably have what's called familial hypercholesterolemia. It's a family genetic thing. That's very difficult to treat, but there are some options.
Yeah, I'm trying hard. I'm fighting every way I know. Kim knows that. But like I said, I can't pay 500, and I do take Repatha, take Zetia, and I cannot take statins because it was affecting my liver, I think it was, and they took me off of it. So have the statins many years ago. So I'm doing the best I can, but I'm writing this down. So when I get with her, I'm going to ask her about something.
Something else to think about, Nancy, is there's a liver production problem, but then there's also a cholesterol reabsorption issue that some people have, and maybe Dr. Bonilla, I can see him nodding, that might want to address that. But that was what my dad ended up having, so it was increasing the soluble fiber in a few of those prebiotics or probiotics that ended up helping him to flush out those little troublemaker LDLs sooner before they could actually get reabsorbed back in the body.
Yeah. Okay.
And I think that's where these injectable medications, they're game changers because they work on the cholesterol pathway differently than the absorption in the liver or even in the gut and digestion. And so definitely, talk to your specialist about that. They'll kind of be able to, and there are definitely patient assistance programs with these medications. And especially if you carry the diagnosis of familial hypercholesterolemia, all these injectables were initially approved for that use. They're approved now also as for patients who are intolerant to statins and even primary hypercholesterolemia, but definitely if they have the familial component, that should give you the indication to absolutely use it for insurances.
Yeah, so far with the Zetia and the Repatha, I've gotten it down to 77, but it's like
that's really good.
Yeah,
and that's actually really good.
I walk every day, and I try a Mediterranean diet. My A1C is almost pre-diabetic, so doing everything I can. This is tough,
I think you're doing all the right things.
I died at 45, and it runs in the family, so thank you. I'll ask.
You're welcome.
Okay.
We have Laura that has a question. Laura, do you want to ask this question yourself? If you do, go ahead and unmute. Laura with a L-O-R-A. Laura, do you want to ask your question? Go ahead and unmute. And if she's not, I have it sitting right in front of me so I can ask the question. She is concerned about some chest and stomach pain along with increased heart rate, although her echo and her heart monitor are normal. What questions should she be asking her doctor, and when should she be getting a second opinion if need be, if her doctor's not listening?
Yeah, so a few things here. I need more information, how the patient is, if there's any prior medical history, how fast the heart rate is going, and what the results actually say. So fast heart rate or tachycardia is not necessarily a bad thing. A normal heart rate is between 60 and 100. So whenever we tell what's normal, what's not normal, we grab a group of people, let's say 10,000 people, we average out their heart rates, and whoever's the healthiest or the most their averages out, the better is what we say is normal. So that means that there's people on the higher end which are normal, people on the lower end which are normal also. So I'd have to kind of ask those questions and see what exactly her heart rate was, how long the cardiac monitor was, whether it's for a day, 2 days, a week, 2 weeks, or an entire month. Because sometimes these things can come and go, especially when we talk about abnormal heart rhythms. So that kind of be another question to ask. And what the exact results will be on the electrocardiogram. There's other things that also want to avoid in patients who have a faster heart rate. Anything that would be a stimulant to cause that. Anything like caffeine, anything like these power drinks, chocolate, anything that has caffeine or can be a stimulant, even medications, dehydration, a very normal response when you're dehydrated and reduces your blood pressure, your heart goes up. It's a compensatory response. So good hydration, kick the caffeine, and then get that information to and if all that comes back normal, or you've had a monitor on for a week and it was fine, the echo is fine. Then looking towards other things, things like endocrine disorders, hormonal, like thyroid can cause fast heart rate. There's a lot of questions that I have there. It's kind of too general for me to kind of directly answer.
And one of the things that just to bring my mom who recently passed, a lot of those symptoms, seem to be relatable to what she went through with her aortic dissection. And it's really important. I think that is an area that a lot of doctors seem to overlook. And if you are having those symptoms, it's always worth asking your doctor to check your aorta, make sure that your thoracic aorta is okay and that your abdominal aorta is okay as well, and that there's no aneurysm in that region.
Yeah, and along those lines, no, I was
ahead.
just going to say very briefly. So when we talk about thoracic aneurysms and things of that nature, a very simple test that kind of help would be blood pressure checks on both arms. Sometimes there's a difference that can give us an idea or kind of lead us down that pathway. It's always a good idea when you go to see your doctor, you tell them to check the blood pressure in the other arm. If there's a big difference, then it's something to kind of go look into.
Well, thank you for that. I hadn't heard that one before. Appreciate it. We do have, I think you're going to recognize the next patient, Douglas, who, I think it was Julie earlier that you were referencing. I know that, getting a doctor to listen to you. And it's, when we finally got Douglas to see you, it was so refreshing to have him come out with hope for the very first time in years with a doctor that actually sat and listened to what he had to say. Douglas, the floor is yours.
I do have to admit, he literally talked about everything that I needed to know. It was really refreshing, Doctor, the time that you spent with me and everything. And you're a great guy.
Thank you.
So my question is, my history. So I've had 2 episodes in the last month, but they seem to be lasting 2 or 3, 4 days now after I have them, where I feel real bad. My chest hurts, my stomach hurts. I get dizzy and I'm sick, but it goes away. But I seem to notice that now.
Yeah. So without kind of delving too much into your history, you're a very complicated, what I refer to at the beginning, vascular path also. So very significant circulation issues and problems, including surgical and what we call endovascular, or what we do fixes. So there's a lot that plays into that. It's kind of hard to pinpoint exactly what exactly is causing that, just because because of the surgeries you've had, and because of the work that's been done to you. The nausea, vomiting, and what was it else that you're having again?
Dizziness, but my stomach hurts and my chest hurts.
Yeah, and so there's a lot that plays into that. Not only the circulation outside the heart, but your circulation within the heart. And the surgery that was done, I think, we've talked that, there's always going to be some degree of symptoms that you had. My focus is trying to reduce those symptoms as much as possible, but being realistic about everything that's that they've done in the past. I don't want to say they've done to you, but they've done with you. And this is one of the reasons we follow up regularly. This would be also, for all the other patients. This isn't just a one and done, one time thing. This is a lifelong type of thing that you should be following with somebody or some people or some physicians with. And it's because of these regular symptoms. And it could be that these symptoms are results or consequences of all the work that's been done. It could be just progression of the disease. Or it could be, that's something that's recurrent or coming back or something else we have to look into. Again, without delving too much into your history, you've actually been quite a challenge for me, which is actually great. And from my perspective, in the sense that, I'm looking for things and, focusing on a lot of things. And 90% of my job is playing detective anyway. If there's any progression of your system, if your symptoms at all, we can totally set you up for a teleconsult visit or bring you whenever you're back in town.
And this is what's amazing. And this is the type of thing that, it's important for everyone to hear. And I like the dynamic there that here's a doctor that says, you're really complex, but you know what, I'm not going to brush you off. And we're going to just keep plugging away and we're going to find something. I'm going to research, I'm going to talk to people and we're going to make sure that you're taken care of. And I absolutely love that. So thank you so much. We have quite a few other people that.
Oh, okay.
Really quick. Yes. Go ahead, Douglas.
Walking.
You're always welcome.
We have a red light candle going, walking. Now, I'm doing the walking now, but I also noticed around 1,500 steps, if I come to a stop, my legs give out on me. And we hear that a lot in the group about walking and getting past that pain.
Yeah. So, the way our walking program, so a class 1 recommendation from our guidelines, which means absolute best data should be done, which is not done, is put in placing patients who have claudication or walking pain due to circulation issues in these rehab facilities that are focused for that. And a close type 1 recommendation is for what we call a community if you can't get into the rehab centers, which is basically just doing at home. What I recommend to my patients is taking a dedicated time 3 or 4 times a week where you set a goal, ideally up to half an hour, maybe more, of just walking. The idea is you walk till you get your symptoms. A lot of people say, or a lot of specialists say, hey, you just walk through it. Well, no. When you get to the point where you start having really severe symptoms, the idea is you stop, you take a break, you sit down if you have to, you let the symptoms pass. Once you feel better and you're able to walk, then you continue to complete your goal. Let's say the goal is 30 minutes. And at the 20-minute mark, your legs are just starting to give out. They're tired, they're fatigued, you have pain. You sit down, you stop the timer, you relax for a little bit, let it pass. And as soon as the legs feel a lot better, you get up and you keep walking to continue those last 10 minutes and reach your goal of 30 minutes. And the longer you do that, the more you do that, the further you're going to be able to walk without significant pain. But the idea is you really shouldn't try walking through it. You walk till you get the pain. You can push yourself a little bit after that, but you don't want to kind of overdo it where your legs actually give out. You walk to the point where you get the symptoms, you sit down, you relax, you take a break, let it pass, and you continue to complete your goal.
Fantastic. And Marie wants to know, what if the cramping starts after about 15 feet?
Yeah, so if we're kind of certain that it is due to circulation problems, and 15 feet, that's pretty low. Definitely you want to continue the walking program, but that probably means you need a more aggressive treatment with medication, cilostazol, or if that's not working or you can't tolerate it, then something more invasive like an angiogram. After it, again, this is if you have diagnosed PAD. We know that this is definitely walking pain from vascular issues, and you're on good medications, but you walk 15 feet and you get the pain. That's not that that's an ominous sign, but that's a sign to get something done, be a little bit more aggressive or invasive with the procedures we offer.
And Mariana wants to know if the new capillaries, or, actually once they start going, these collateral vessels are known as actual arteries. If they can grow, then can PAD actually get better, even go away? And we know that there's no cure, but we have had quite a few patients that have been told that amputation was the only option, and they just push through, and they have not had an amputation, and they could just continue to walk and push through further and further and further. So it is possible to stall progression. And move forward with your life, right?
Yeah, and I think this is actually a great point, something I want to address here, being what we call PAD or CLI, critical limb ischemia fighters, is that if anyone is offered amputation as a first option, that is the absolute wrong, unethical thing that should be done here. That means that number one, they're either too lazy, or number two, they don't know what they're talking about. Amputation should never be the first option unless it's in a very, very specific setting where the tissue is already rotten, gangrenous, and that's what we call wet gangrene. There's active infection, and there's no salvage to that tissue. That is the only time that amputation should be a first option. And I'm very passionate about this because everywhere I go, especially in my first practice, this is something I've had to fight with because there isn't a lot of education to this, even as physicians. And that includes primary physicians and any other specialties also. If they're quick to amputation, that's something to think about, and that's the wrong thing to do. But yes, definitely walking helps you. The walking program has some of the best data and research behind it. That's why it's a class 1 top list recommendation. Even though you have blockages, does not necessarily mean, especially like not necessarily mean that you have to fix these blockages. And that's why a walking program and these medications are first line therapy before anything more invasive. And a lot of these patients with just walking, strengthen those collateral circulation, the reroutes, strengthen the circulation you have left, and a lot of this pain gets better. And a lot of these patients, I've had patients for years to decades, or even never requiring any type of intervention or invasive procedure, even though they have completely blocked arteries.
Now, for someone who has both CAD, coronary artery disease, and PAD, and they're in a cardiac rehab program, they're an intermittent claudicant. They have to rest every 10 minutes. Are they getting the benefits of the cardio rehab? Or should they have a little roto-rooting in order for them to walk a little bit further so they can also get the benefits of cardiac rehab?
Yeah, I think there's always
Tough
benefit
question.
to cardiac rehab, and definitely cardiac rehab programs also have the component of the PAD programs also for the most part. In most places, they double cover. And even if you can't, interestingly, when it comes to, there's data to with our PVD programs, and I make a presentation about this every year in El Paso. But with cardiac rehab, even though you can't walk for long periods of time, and there's 3 main exercises we use there: the treadmill to walk, we use the arm ergometry or the cycle, and the leg cycle also. Even if you can't walk, the arm cycle and leg cycle actually increases your walking distance without claudication, believe it or not. Even though you're not walking, it's because it strengthens those arteries because of the circulation. But yeah, kind of going back to what you were referring to, Nick, Kim, I think if it's definitely, again, a vascular issue, if you're walking, continue the cardiac rehab, continue the PAD rehab, whichever or both of them it is. And if there's if after a reasonable amount of time, usually about a month to 1 to 3 months, if there's no significant improvement and you're still having pain, then that's probably an indication to be more invasive, go in and unblock those arteries.
And we had a question that came in a little bit earlier about how artery blockages can ultimately impact the venous system and lead to ultimately chronic venous insufficiency as well.
Absolutely. So the arteries and veins the arterial and venous system are 2 different systems for the most part. Arteries are higher pressure, they're more elastic. Veins are lower pressure, and they have these valves which help you have to work against gravity. So a lot of these risk factors that apply to PAD also apply to chronic venous insufficiency. Things like being overweight, things like being sedentary, high blood pressure, cigarette smoking, all these things damage the veins, and specifically the valves and the veins. And so usually artery issues are accompanied by vein issues. So, and then once you address the artery issue, you have good blood flow going into there, you're just not getting good blood flow out. And so in more specialized centers like our own, we focus on a complete peripheral vascular, not just PAD, but PVD. to include the arteries and the veins, because we can get blood flow in there a lot of times, but it doesn't mean that we're getting blood flow out. And when it comes to venous insufficiency, chronic venous insufficiency, those valves in the veins are damaged. At that point, you're fighting against gravity. You can't get that blood flow back to the heart. You're getting all the blood in there. So what happens classically with these patients, by the end of the day, on your feet all day or sitting all day, the legs are really swollen. And these patients tell me, hey, in the morning, my legs feel great. Well, it's because during the day, gravity's pulling everything down. At night, when you're laying down, you elevate your legs and you're helping gravity pull it back to your heart. So that's why they look better in the morning. But veins should be addressed also after the arteries, because arteries are arguably more important. And again, if you're having symptoms that would indicate you have chronic venous insufficiency, big bulging painful veins, swelling in the legs, walking pain, which you can get from veins due to the swelling and chronic venous insufficiency. So that's also a different topic, and these are things that we deal with here in our practice also. But yes, absolutely, it can affect the veins.
And Mike wants to ask you about LDLs. What goal are standards set for when it comes to LDLs? His is 68. Does he need more statins? I know you addressed this a little bit earlier. Would you mind talking about those standards and goals?
Yeah. So when it comes to these, our recommendations and our guidelines, we're constantly having new updates, and I think part of it has to do with a lot of us wanting to put our names in some of these studies. And I refer back to the 1980s when you had these videos, these 10-minute workout videos, right? And say you can have everything you need in this 10 minutes. Well, the next competition comes out and they say, hey, listen, this is going to be better than the 10-minute workout. This is the 8-minute workout, right? And then you have the 6-minute workout that comes in. And so I think this is a continuum of that process. Ultimately, the big picture here is that LDL is bad. So any reduction in LDL is great. Initially, they would tell us, hey, listen, everyone has to have their LDL under 120. Then it went to 100. Then only diabetics should be below 70. Everyone else should be below 100. And then some other studies, I believe it was the ATP3 guidelines, they came out and they said, hey, listen, we don't have to go by a specific number as long as we have a reduction in 50%. So there's a lot of conflicting information and data, even within our guidelines and our societies. I'm a very common sense person, and this is what I tell my patients. We know LDL is bad. Any reduction in LDL is good. I do believe in that number below 100 for the most part for many patients. I do believe for diabetics less than 70. The newer guidelines for patients with issues with hypercholesterolemia or diabetes should be less than 55. So technically, if you have peripheral vascular disease or coronary artery disease, or even a history of stroke, your cholesterol should be, or your LDL should be the lowest possible. And per our guidelines, currently it's 55. I'm still a 75% person myself. I think if we can get you around 70, I think we're good. Because like in Nancy's case, I think, it's going to be difficult to get you past that. But I think with that reduction, that percent reduction, number one, but also getting you to that number reduction close to 70, I think that's actually really good for you. But yeah, going back to the original question, per our guidelines, LDL less than 55 with reduction of 50% is what the magic number is for patients who've had either events, heart attacks, or issues with blockages in their legs.
And Marcia wants to know, can LDLs be too low? She's at 38.
Yeah, I get this question a lot, and I've seen LDLs down into even the 20s. I have not noticed any significant side effects. I think bad cholesterol is bad cholesterol. I think you need some degree of it or some amount of it. But there's some research going on right now about lower LDLs. But my take currently is that the lower the better. If it's 38, that's great. That's perfect. That's where we want it to be. Now I probably wouldn't be any more aggressive than that, add any other medications, because we just don't know. But I think, the lower the better. And there's really no documented or significant large-scale side effects that are associated with having an LDL that low.
And Douglas wants to know, what is the difference between HDL and LDL cholesterol?
That's great. So it has to do, just kind of putting it in a context where we all can understand. Cholesterol has, you have your total cholesterol, which is a combination of all the different cholesterols that we can measure in your blood. the triglycerides, which are the fats in your blood. You have VLDL, which is a type of cholesterol a unit. And then you have the classic, the good cholesterol, the bad cholesterol. Yeah, the bad cholesterol is the low density lipoproteins, the LDL. And the good cholesterol is the high density lipoproteins, or HDL. And the easiest way to think about it is that the HDL, the good cholesterol, binds to the LDL, the bad cholesterol, brings it to the liver and excretes it from the body. So you want a lot of high good cholesterol, HDL, because the higher the HDL, the more binding you're going to do to the bad cholesterol and excrete it from the body. So a higher HDL is actually what we shoot for. There's not a lot of things that increase your HDL naturally, though. Even medically, there's not a lot of things that increase your HDL. And so it's a difficult area. And there was a lot of research in the late 90s and early 2000s going into how do we increase HDL. And there are things like omega acids and certain types of fish, the omega acids, but these are very therapeutic doses, higher doses that actually help to increase that. But the difference is that HDL is good, LDL is bad. HDL binds to the LDL, takes it out of the body. So the higher the HDL, the better.
And Peggy has a question. She's on our YouTube and she wants to know about femoral endarterectomies and whether they can fail.
Yes. The answer is yes. So an endarterectomy is basically filleting the artery open through surgical means, scooping out the cholesterol, sewing it back in. So it's a very invasive procedure. I'm not a surgeon. I don't cut. I'm a plumber. I do everything through IVs. But we have vascular surgeons who are dedicated to circulatory problems. And endarterectomy is actually a great therapy. So basically in the groin here, which is the common femoral artery, which is the entrance to the leg, those arteries can become narrowed, blocked up, or highly calcified rocks in there. And so usually when it's a big rock in there, it's hard to kind of go in there and unblock those arteries from the inside with the plumbing that I do. So a lot of these patients, I do refer to these vascular surgeons. Basically, under anesthesia, they'll open up that area, they'll clamp the artery, they'll open it up, they'll scoop out the big rocks of the cholesterol blockage in there, and they'll sew it right back up. It is an excellent therapy, but yes, they can fail. And so progression of the disease, once you have blockages from PAD, you're always at risk from having further blockages. So that might be a reason it fails. And not taking your medications, not walking, not losing the weight, and controlling these risk factors, those are also reasons that these things can fail. It's very rare that you have, a surgeon who does a botched job or something like this. This is what they do. That's their specialty. So even that's lesser on the reasons why. So probably more to do with the degree of disease somewhere else, or the patient just not taking care of themselves.
Yeah, and can they go back in and do a redo on the endart, or is that something that you as a plumber can go back in and at least attempt in those areas that have had a previous endarterectomy? Can you go in a minimally invasive way with wires and catheters and balloons and try to do a little rotor rooting there?
So the quick answer is yes, but there's a lot of kind of caveats to that. So when a surgeon touches someone or does something to it, you have to be very careful to go ahead and intervene from an endovascular, from an inside perspective of balloons and stents. That area has been manipulated. Your body has responded with some type of inflammatory response or some type of response to heal the area, not only from the outside, but also from the inside. And so timing of when the surgery is a big one. And one of the other things we run into as specialists is we don't have a lot of times readily the reports from other specialists available. Or even able to get them. We know that there was a procedure performed. We don't know the details behind it. If there was any complications, how long it was, if the patient tolerated the procedure well or not. So I'm always weary about going in and trying to fix surgical issues. Not that I haven't. I've fixed bypasses before. I've opened up arteries across bypasses before. I've fixed endarterectomies before. But it's all about getting to the right person, the right specialist to kind of guide you down that path. But the quick answer is yes.
Yeah, I mean, I'm sure you've bypassed bypasses that other doctors have not been able to, with blockages that others have not been able to get through or never even attempted. So we always say that if your bypass fails or an dart fails, it's always really good to get multiple opinions. And, you know, as Marie is asking, how often do you have to have a redo on bypasses and stents and things like that? And it does depend on the person. And it is always good to get multiple opinions to make sure that you understand all available options out there, because one doctor may have a certain skill set and another one might have an entirely different skill set. So get multiple opinions to understand all available options. Marcia is on the line, and Marcia has a question she wants to ask. Marcia, go ahead and unmute and ask Dr. Bonilla your question.
Was it about the fish oil?
That's what it looks like.
Yeah. You were talking about there were very few ways to up your, and I get the HDL and LDL confused. The HDL is good. Is that right?
Good cholesterol.
So for years, I took fish oil supplements to no avail. Nothing really helped me on either of them except for lifestyle change and, you know, quitting smoking, exercise, and diet. And so I'm wondering, what are your thoughts on fish oil supplements in general?
Yeah, so I am always cautious about this question because the omega acids that are found in certain fish oils are the ones that have health benefit. Now, fish oil isn't bad for you, but and there's certain types of fish that have more omega-3 fatty acids than other types. But the medical benefit that's been shown in the studies from omega-3 acids are in medical or therapeutic doses, which are really high doses. So there's a medication that we actually prescribe, not as often as we used to, which is EPA, eicosapentaenoic acid. It's something like that, and it's medical grade, basically omega acids, and it's very high doses. It's something like 1,000 milligrams, a couple times a day or something like that. But that works to increase your HDL, your good cholesterol. And we use it as a secondary, even tertiary medication for patients who just can't get that LDL down, like Nancy's, far enough. And the idea is to increase the good cholesterol, but there's a lot of side effects that can happen with having those high doses also. Those supplements, fish oil that are found GNC or these health supplement stores, usually not from the fish, number one, usually not the doses required to comply with the studies that have been shown to increase the LDL or HDL and have any benefit to it. So I'm always wary about these fish oil supplements. It's not going to hurt. It's not going to give that benefit as much as you want.
Can they go rancid as well? So like if you're taking it and it's not a huge benefit, if it's old, can it be detrimental?
Well, I think any medication, and I'm sorry if I'm going in and out of the light here, I'm walking around, but I think any medication that has been expired shouldn't use. And I know there's two types of people in this world, right? Yeah. Those who throw away the medications that are expired or the things in the fridge that are expired, and those who say, hey, got another couple months to it. I'm one of those people that throw it away if it's expired.
Fantastic. We don't want to take up too much of your time. Anyone else have some questions on here that we want to jump in? I know we have quite a few people still on here, and I want to make sure if you want to unmute and just go ahead and pop in with your question, you can, or else I'm going to get to our last question of the day that also came in. So if you want to unmute, go ahead and unmute now, and we'll try and pop you in with a couple of the questions. Okay. Well, then I'm going to ask Letitia's question that came in that she wanted to make sure I asked you. She ended up with peripheral arterial disease due to radiation damage to the leg arteries when she had uterine cancer. She's slowly losing her ability to walk. She also has some lymphatic issues. She's only 44 years old, and the doctor said there's absolutely nothing that can be done for her. Is there any hope for her? She's only seen a surgeon.
There's always hope, especially if you've just seen a surgeon. And it depends on the surgeon and the specialty also. So we share this area of medicine with at least a few other different specialties: interventional radiology, vascular surgery, and then our other counterparts with help in other areas: our podiatrists, our infectious disease doctors, and our primary doctors. I think anytime you're told there's no hope, there's no other option, it's always a great idea to get an opinion from someone who can potentially offer you another option. I deal with patients who have radiation injuries a lot, patients who've developed PAD or circulation issues from certain medications, which is also a thing too. And so there is always at least some hope, and it's always a good idea at least to get a second opinion. There's nothing wrong with getting a second opinion or a third opinion if you're not comfortable. And the physician that's taking care of you, even if they've been taking care of you for 30 years, should not have a problem with getting a second opinion. So my advice to that is absolutely get a second opinion. Get it probably a different specialty. Look for a vascular specialist. If you're seeing a surgeon, try an interventional cardiologist. Try a vascular specialist. They have vascular medicine specialists also out there. Have Kim help you look for somebody. I think there are definitely people out there, but absolutely there's always options. I'm involved in a couple of trials, and I do a procedure for our no option PAD, very advanced critical limb ischemia patients. So even when they don't have options and no one else can offer them options, we do have some option that gives them some hope. It doesn't work all the time, but it works, a good 70-80% of the time. So there are options for you. Absolutely.
Fantastic. And we're just going to end on the very first question that we had advertised that we were going to talk about is, the difference between coronary artery disease and peripheral artery disease, and why PAD patients are at higher risk of CAD.
Yeah, so it's a good question. I think what we have to understand is the process, and I alluded to this before, of all three areas. All of them start with atherosclerosis, hardening of the arteries. This is all a continuation of one process. This process doesn't just happen in one circulatory area. It happens all over. High blood pressure affects all parts of the bodies. Your heart has to work extra hard against that high blood pressure. Again, atherosclerosis makes these tubes very rigid. Usually they're very elastic. So it's easier to pump blood through an elastic tube than it is a rigid tube. And so your heart has to work harder. In the legs, you're working against gravity, you're working with gravity. And those, again, arteries aren't elastic. So you're having to pump more blood through a very smaller orifice that's blocked off. It's like putting a finger over a garden hose. It comes at a higher pressure. Same thing in the brain with patients who have circulation problems in the brain. So that's why there's a correlation between patients in this context of CAD and PAD. And usually the number they throw out there is a 30% correlation. I think there's a lot more. And so a patient who comes in who has a history of CAD, who has all the risk factors, always a good idea. This is what I do. I ask them about the walking pain. I ask them about any pain they have in their legs. I check their pulses and their feet, the pulse on the top of the foot and then the inner ankle. Those are the two of the main pulses. And if there's any indication that those pulses are abnormal or low, get an ABI, get an arterial Doppler or ultrasound, especially in that setting because of the correlation. It's the continuing process. Atherosclerosis, hardening of the arteries, which causes a progressive narrowing. And again, this is a process that happens all over the body. So we should understand that it doesn't just happen in one area. It happens in different areas. So that's where the correlation comes from.
Thank you so much, Dr. Bonilla. I just want to point out right behind you is a very special plaque that our PAD warrior, Douglas, had designed for you. Look at that, PAD life limb. What does it say? Saving superhero. I love it. PAD warrior. Thank you so much. You definitely are, Dr. Bonilla. And thank you to Douglas. Oh, look at this. Oh my gosh, that is absolutely beautiful. Wow. Douglas, that's amazing. So thank you so much for putting those up. They're absolutely beautiful. And thank you for all you do, doctor. And thank you for taking the time. Dr. Jonathan Bonilla over there in San Antonio. Are you also working out of Corpus Christi as well, or just San Antonio is your base?
San Antonio, Seguin. Seguin is my main base. I work a couple of days in San Antonio. But yeah, no, Corpus Christi is my partner, Jason Yoho, who's also one of our PAD CLI fighters too.
Fantastic. Thank you so much for joining us. Thank you so much, everyone, for being here. We really appreciate your time. What's Up Doc is every single Tuesday, a different doctor, different time, but not a different day. Thank you so much, doctor.
My pleasure.
Thank you.